Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan. Now, here is your host, Joe Steckler.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is stroke, peripheral arterial disease, and abdominal aortic aneurysms. Joining me today is Dr. Dwayne Badget, Brevard Vascular Associates, on staff at Wuesthoff Medical Center, and Dr. Shah, Neurologist, also on staff at Wuesthoff Brevard County Center. And Dr. Shah, how do you pronounce your first name? I didn't try it because I knew I'd mess it up.
Oh, that's okay. It's Viabhav.
Viabhav. I had Dr. Shah on my radio show, folks, and I had a heck of a time with that first name at that time, and I did it again, so I decided I wouldn't try to tongue twist myself. I think when we were sitting here talking before we went on camera, we're talking about the relationship stroke and peripheral arterial disease, and as our show unfolds, I hope to develop somewhat of a connection. I think many people are more familiar and aware of stroke, not so much what causes a stroke or what to do in the event of a stroke, but the word stroke. But Dr. Badget, I don't think many people understand what peripheral arterial disease is, and a related subject, since I happen to have one, an abdominal aortic aneurysm. First, let's talk about your specialty and what you do and what is peripheral arterial disease.
My name is Dwayne Badget. I'm a vascular surgeon. I specialize in peripheral vascular surgery, venous surgery. But one of the growing problems, and I'm glad we're addressing today, is peripheral vascular disease. Simply put, peripheral vascular disease is the occlusion or plugging up of an artery with cholesterol, platelets, and other clotting factors. When that happens, that can eventually lead to symptoms such as cramping of the leg, pain in the extremities, and possibly even loss of an extremity. So our job many times, being on the forefront of healthcare, is finding those patients who are not symptomatic and who can best be helped by our intervention. Most commonly, peripheral vascular disease is associated with lower extremity problems. Patients may present with cramping in the calf area or pain in their feet at night when they go to bed. These are the symptoms that we need to pick up. However, there's sometimes, and unfortunately, there's millions of people who have no symptoms. And these patients are often picked up by an intuitive physician who might detect a decrease in their pulse on physical examination.
What are some of the dangers of peripheral arterial disease?
Well, specifically looking at the dangers which I deal with, they're more associated with lower extremity problems, such as lifestyle limiting pain in the leg, or what we call claudication. It's where you walk up until a certain distance and then your calf cramps up and stops you from walking, usually for 4 or 5 minutes. After rest, you can walk that same distance again, but usually not further than that. These are one of the more subtle and earlier signs of peripheral vascular disease. The next step is something we call rest pain. This happens when the blockage is so severe, or there are multiple blockages, and now people have pain in their feet or their toes at night when they go to bed. Often it wakes them, and they hang their feet over the side of the bed to allow gravity itself to pull the blood down to their foot, and that relieves their pain. Unfortunately, many people assume a lot of these signs and symptoms are just a factor of getting old, and they're often ignored by patients, and unfortunately, even in healthcare, we don't always see these signs. And those people where it progresses, they can go on to actually develop something called gangrene, where there's a total lack of circulation to the toe or to the rest of the extremity, and unfortunately limb loss rate is very high if that happens. So these are the things we try to prevent locally. However, Dr. Shah and our specialty, we often overlap because Many patients, again, are undiagnosed or their symptoms are very mild, but patients with peripheral vascular disease also have a high chance for having coronary disease, as well as disease in their carotid arteries, which can lead to stroke. So I would say those are the dangers of not picking
Dr.
up.
Shah?
Yeah. So I would agree. There's certainly a lot of overlap in our two fields, and it's the same process. The location of the arteries is different. Peripheral arteries more in the extremities, and the arteries supplying the brain. But the process is really similar. The risk factors are similar, and so someone who's at risk for peripheral artery disease is also at risk for cerebrovascular disease. And so I think it is important to look at those risk factors, modify them, and address these issues really from both ends, because if you reduce the risk of peripheral artery disease, then it also could reduce the stroke risk.
I think that's an important point.
If I wanted to say, to simplify the thing, if I took my body and cut it right here in half, would the peripheral arterial disease affect what the bottom part more than, and your special would be from here on up to the head? Is that a way to look at it? Well,
in general terms, when we talk from a medical profession, we talk about peripheral vascular disease. We're almost talking about everything except for the heart. So the arms would be included, the carotid arteries would be included, even the vessels supplying the stomach itself and the other intestines. That's all considered to be peripheral vascular disease. So I guess to make it even easier, I primarily deal with all the arteries and veins except for that of the heart, which the cardiothoracic surgeons take care of. That would be more central disease, whereas everything else is considered to be more peripheral.
Okay. I've had a dissecting ascending and descending aorta all the way down to where I have an aneurysm on my right iliac. That's an abdominal aneurysm. That's your field, right?
That's my field.
3 months ago, I had a stroke, and I had a hemorrhagic stroke. Mm-hmm. That is more your area, right?
That's correct, yes.
Did you say you were a surgeon?
Yes, I am.
In the treatment of abdominal aneurysms, is there a cutoff or at some point which you can use a stent or not use a stent to fix an abdominal aneurysm if it's on the iliac?
Well, that's a good point. When this procedure was made available to the general public, which I believe was 1999, there are many limitations out there. We already had a good operation, and this was a new thing that came along. And what I've noticed over the years that every several years, the number of patients we can treat with stents has grown to the point where in some institutions, almost any aneurysm we can treat now with a stent, with a few exceptions. But iliac artery aneurysms typically can be fixed very well without problems with the covered stent.
I was told that the location of my aneurysm is far enough to the outside on the iliac where they can't put the sleeve down where it branches out. Mm-hmm. They can't put the stent over. Does that make sense? Or am I listening to old technology too much?
Well, for common iliac artery aneurysms, which are slightly more common, usually we find a way of fixing most of these. I haven't ran into one yet that we've not been able to fix, either by putting in a graft that fixes your aorta and iliacs at the same time, a so-called bifurcated graft, or a sort of uni-graft which goes up just up your right iliac. So having not seen your x-rays, I would say most common iliac artery aneurysms, we find a way of fixing these with a stent nowadays.
Maybe what I need to do is get my CT scans and get them to you and have you take a look at them.
I think that might be a good idea.
In fact, I'll do that.
Okay.
When I started this show, I talked about Information and Education Resources Bureau. That's why discussions like Dr. Badget and Dr. Shah and I are having today. That's why it's so important to do these things, because there have been so many changes in medicine. I did a show recently with 4 of your surgeons on robotic surgery. And listening to those surgeons describe the different techniques and the simplicity of very complicated operations. It just makes me angry that more people that have these problems don't have access to the type of information that the three of us are talking about today.
You know, I think it's a great idea. We are talking about these things because so many people just don't know what's out there. And with technology changing every year, it's almost limitless what we can do these days. So I think it's very important to get this information out to the general public. And again, as we said earlier, often people are unaware of some of the signs and symptoms of peripheral vascular disease or some of the earlier risk factors that they can modify to prevent them from having strokes. So this is, I cannot sort of even explain the importance of the discussion I think we're having.
Dr. Shah, I haven't let you talk very much, but I want you to talk more about stroke because the subject of strokes is very near and dear to my heart, and since I had one. And we did a show on emergency room medicine, and the doctor and nurse that admitted me, and she also admitted to putting the tube down my throat. She said she did that, and she told me why she did it. So many people don't understand why doctors do some of the things they do. First and foremost, they keep you alive. And the subject of strokes, treating strokes, as a doctor that you're as a neurologist, what are some of your main concerns about lifestyle, risk factors, and what people can do before they get to the point where they may have a stroke?
Well, I think that's an excellent question.
That's a loaded question, yes.
It is, but I think it brings up a good point where when a patient sees someone like me, it's after something has happened. And I think we do need to focus on the before. And even afterwards, a lot of what we talk about is stroke risk reduction. And so it's important to understand what the risk factors are and what we can do about them. So there are a couple of risk factors that we can't do anything about. Age and genetics. Those are risk factors. We can't modify them, but there are risk factors that we can modify. And so part of it is lifestyle. So staying active, having a healthy, balanced diet is very important for cerebrovascular disease and for brain health. And other things are also addressing medical risk factors. So things like hypertension, diabetes, hyperlipidemia, atrial fibrillation. And these are all things, if managed properly, can significantly reduce the risk of having a stroke in the future.
You mentioned atrial fibrillation. According to all that I read, atrial fibrillation is one of the greatest contributors to stroke. And how about in your field of peripheral arterial disease and aneurysms, in your field of stroke, explain to our viewing audience why I'm going to use the terminology clogging of the arteries is so important for people to understand. Understand from the viewpoint what they can do to prevent their arteries from getting so clogged. Can you go first, Dr. Shah?
Sure. Well, I think the first thing is really understanding what you can do is reduce the risk. There's no way of preventing, but we want to reduce the risk, and every little bit counts. And so I think the first step is really the lifestyle, is a healthy, balanced diet, getting exercise. One other lifestyle risk factor is cigarette smoking. That's a huge risk factor for arterial disease. And so it's really important to live a healthy lifestyle. And then the other thing is really the medical risk factors, seeing a doctor regularly. If you have any of these medical risk factors, addressing them and being diligent about following through as far as hypertension, diabetes, high cholesterol as well.
In all of my work with doctors and in studying for all these TV shows, one basic underlying cause that I find as a root evil for almost every disease is smoking.
That's right. That's right.
How? And you're really shaking your head because I think it must bother you, Dr. Badget. But how can we convince people that smoking is really a detriment to improving our quality of life?
Well, I'll tell you, I think if I really do find the answer, I'll have one of the secrets of life, because it is one of the most frustrating things that I deal with, and we all deal with. Every day I counsel patients for, individual patients for 10, 15 minutes at a time, purely just talking about the importance of quitting smoking. It's up there with the number 1 or number 2 risk factor. You have hypertension, you have smoking, but this is a preventable risk factor. Smoking itself, what I explain to my patients, I try to break it down in simplistic terms, because I believe that despite the addictive factor of smoking, I think at the base of it, we're all reasonable people and all knowledgeable people, and if I can kind of address that issue many times, I'm very fortunate in my practice, 1 or 2 people quit a month. And the main thing I try to do is explain it in simple terms. I explain to them that the tobacco, that the nicotine and other contents of the cigarette physically damage the artery. It takes an artery that should be smooth like butter and turns it into sandpaper, making it rough and more adherent to clotting factors. It causes the artery to go into spasm, which is a tightening of the arteries itself. And that also limits the blood flow to the extremities and the other parts of the body. So what I try to do is not just say smoking causes cancer, because everyone's heard that already. Everyone thinks everything causes cancer. I try to take each patient individually and tell them what it's doing to them. And what I might tell one patient might be different than the next patient, because their problems might be different, both caused by smoking. So for myself personally, I try to break it down in simple terms and show them in their own bodies what smoking is doing to them. And many times, again, it's frustrating, but I've been fortunate to have, I think, a higher rate of success of people quitting than often I expect. It really takes me by surprise. The people that come in one day and say, "Look, Dr. Badget, I have a surprise for you. I quit 2 months ago or a month ago." So that's probably one of the most rewarding things I deal with. The other risk factors, which we've talked about also, which I also find frustrating, but this is less preventable, but it's definitely something we need to treat, is diabetes. Diabetes, in my line of business, affects the smaller arteries of the body, which often really makes healing and bypass procedures and stenting unsuccessful. So that's another big risk factor I fight. Besides smoking, diabetes is the other one I feel it's on the rise and a problem in our society.
As a neurologist and as a vascular type person, what kind of importance can you, and you used the word nicotine, what kind of importance can you attach to the people that use these new electronic cigarettes, where they take the liquid nicotine and put in this tube and they inhale the vapor? And the reason I made it because Rush Limbaugh went nuts on the radio talking about this thing being not being harmful. I would think it would be harmful.
I think the jury's still out, and I think people are pointing out some harmful effects of taking in sort of this raw nicotine. I guess the trade-off is that this average cigarette has all these other chemicals, which I'm not even sure what's in them, which also cause damage. So if you reduce the intake from 100 chemicals to 1, maybe that's somewhat of a trade-off that I accept sometime. But I agree with you. I think the jury's still out, and I'm not really sure where it's going to go with these either, to be honest with you.
It's interesting to have you say that, because what I'm hearing you say, though, is that what we don't know about the unknown, we better be careful before we go ahead and attack it or use it too much.
That's right. Exactly right.
Dr. Shah, Dr. Badget, I asked you before we went on camera about the connection between your two specialties. And you both had comments to say about plaque, cleanliness of arteries, what the neck arteries can do, what the leg arteries can do, what the arteries going to the brain. Can you explain, maybe you go first, Dr. Shah, and the importance of our viewing audience understanding when they do something to adversely impact those areas, why it's so dangerous?
Well, I mean, we can explain it from a scientific basis, but I think taking a step back, just explaining it from a practical basis. If the arteries have disease and we increase the risk of stroke, stroke is a life-changing event. It's the leading cause of disability in the U.S., third leading cause of death. And so when someone has a stroke, it totally changes their life. At best, they have a good recovery and are able to go back to what they were doing functionally, but they're at risk for stroke again. And at worst, it could be severely disabling or even lead to death. And so I think it's very important to address those risk factors because it totally changes someone's life when they have a stroke.
And since if I had a stroke, I'm at risk for another stroke. So what would you tell me if I was your patient and I'd had a stroke? What would you tell me not to do?
Well,
or do?
So that's a good question. And a lot of it is individualized.
Okay.
Risk factors vary, lifestyle varies, and so a lot of it is tailored to each patient. Specifically with the lifestyle, I think, the healthy diet, exercise as tolerated, as reasonable. If someone is continuing to smoke cigarettes after a stroke, we do advise that they quit, and we're very firm with that recommendation. I think that's probably one of the biggest lifestyle issues. From a medical perspective, it really depends on what risk factors the patient has. If they have atrial fibrillation and they've had an ischemic stroke in the past, it's an irregular heartbeat where the heart is prone to form blood clots that can break off into the brain, we may recommend blood thinners. If someone has uncontrolled high blood pressure or diabetes, we recommend that those issues are addressed and treated. And I think the key with all of those is really just identifying them, coming up with a plan with your physician to address them, and then sticking to it and following through and reevaluating and adjusting as needed.
That's exactly what my cardiologist said to me. What you just said to me, that's what he said to me. And in fact, I just saw him very recently, and he said, I want to see you again in such and such time. He said, however, if you notice anything different, he said, I want you to call me right away. Because he knows that I try my best to recognize the changes in my body, the signals that tell me I need to talk to him or my primary care doctor. Hearing what Dr. Shah said, Dr. Badget, as a dealing with aneurysms and cleanliness of arteries and peripheral arterial disease, what would you add to what Dr. Shah said?
Well, I think I agree with everything he said, and the main thing I want to stress from my point of view is that, and I may have even mentioned earlier, is that the importance of pointing these symptoms that you may or may not be having to your physician. Because one of the biggest problems is undiagnosed peripheral vascular disease. There are millions of patients out there with disease, and unfortunately there's millions of people who have not been diagnosed. And the problem is that if these symptoms are not picked up and the risk factors are not modified, then it leads to a high chance of having cardiac disease or stroke. And I think the important thing is prevention. So the one thing I would like to get out to patients is just be aware of what's going on with your body. Don't accept the signs and symptoms and aches necessarily of the aging process because they may be subtle signs of peripheral vascular disease. And if we can prevent you from not only having complications of peripheral vascular disease, but also of cerebral vascular disease and cardiac disease, that's the greatest sort of reward, I think, of all.
I found in my own case that once I knew that I had the abdominal aneurysm, I found that it was much more of a common problem than I thought. Many people have have stomach aneurysms that are simply not aware of it.
That's a big problem, actually. I can remember my training, before MRIs and CAT scans and ultrasounds were done routinely, many times people didn't find out they had an aneurysm until it ruptured in the emergency room. And as we know, once these rupture, the survivability is very low, with only 5 to 10% of people actually surviving the whole process. So recognition ahead of time is of most importance. The problem is simple physical examination is usually not accurate. The average aneurysm cannot be felt until it's 5 centimeters in your average male. Females, sometimes you can feel them tend to be a little bit smaller. You might be able to feel a smaller aneurysm. But physical exam is not that good for this. So fortunately now, with all the, again, other modalities of ultrasounds and CAT scans, we're picking these aneurysms up smaller, and we can follow them and then fix them electively before they're an issue.
That's what they do in my case. Mine started, I think it was 3.2, and every 12 months they do a CT scan to see if there's any significant growth.
That's right.
So far, there has not been.
Good.
I think it's sort of maxed out at about 3.8, but they watch it. What I find very scary to me is that with the cost of medicine and with the changes in medicine, so many people will not have an opportunity to find out they have problems that both of you address that can only be found out with an MRI or a CT scan. There's no other way that you can detect an aneurysm or clogged arteries that could cause a stroke. Is there, that I'm aware of? Is there anything else that they could look at?
Well, you're right about it. In terms of the most common accurate ways, of course, physical examination is how we're trained to sort of to look for these things, but the problem is it's somewhat inaccurate. You can put a stethoscope on someone's carotid arteries and you might hear what we call a bruit, but again, that's not always going to be accurate. If the degree of blockage is too small or sometimes even too great, you lose that bruit sound. So you're right. It's, having access is a very important part of picking up these aneurysms and as well as peripheral vascular disease.
As doctors, are you both, is either one of you concerned about the directions that we don't have much time, but the directions that healthcare is going? Do you think it's going to adversely impact people that have problem areas that you both are familiar with? Dr. Shah?
As far as I'm concerned, I tell people I've wanted to do this all my life, since I was 6 years old. So no matter what direction it goes, I'll still be here doing it. Ideally, hopefully, we're add more people to the system that we can pick these things up, who have potentially access to ultrasounds and CAT scans and MRIs. But again, I think back to the point earlier, we'll see, and I have no idea which way it's going to head out, but I'm always hoping for the best.
I would agree. I think it's an interesting time in our history right now. I'm not sure where the industry is going to go. No matter which way it goes, I'm going to be here.
I hope you are, because I certainly enjoyed having you on my radio show, and I'll look forward to getting you on my radio show.
Sounds good.
Too. But I want to thank both our doctors, and I want to thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call us at 321-473-7770. For more information on senior care and resources, visit our website at helpingseniorsofbrevard.com. And be sure to listen to Focus on Seniors every Thursday morning on radio station WMEL AM 1300 at 9 a.m. And also look for us every Thursday morning in the Florida Today Health section of the newspaper for our Focus on Seniors column.